All right, you guys all ready? Cool. Let's jump into it. Patients with special challenges. There we go. So we're going to talk about a number of different patient types that we're going to see out there. And that's kind of one of the cool things about what we do, right, is that we're kind of jack of all trades, master of none of medicine, right? We're really good at emergencies, but we have to know we need to know a little about a lot. A lot of medical stuff is really specialized. We're not. So we're going to see a lot of different patients that maybe certain other responders or other healthcare providers might not see very often. You're going to see a lot of people taking care of themselves at home, and we're going to be the ones that are going to show up when something's going on, right? So we need to be aware of a lot of different things, different stuff for the heart, like an LVAD, or there's people with complete heart replacement, or not replacements, like complete mechanical hearts that you might see, or different like long-term chronic medical diseases that people are going to have at home that we're going to have to know something about to help them treat. So something we really need to be aware of. And then, some of the more straightforward stuff, people who are disabled with hearing or speech or vision, those kind of things, right? So it's a pretty wide spectrum for us that we're gonna have to deal with. You might see all sorts of ventilators and pumps and all that kind of stuff, right? You probably don't know anything about it. Don't get distracted by that. Good patient care is still good patient care, right? If somebody's on a ventilator and the ventilator's having an issue, you guys have a BVM that does the same job, right? We have ways that we can work around these things, so don't fall too much down the trap of that stuff. And don't forget with all these things that you always have medical control, you always have resources you can contact if you're not sure what's going on, right? I'm a 911 medic. If I were to go run interfacility with some of these different pumps and stuff that they have to deal with, I'd have no idea what I'm doing. But I'd just make sure to get resources online that do know what they're doing with that stuff, right? There's been multiple times where I've done a transfer and from like a hospital somewhere that I've been like, I need a nurse because I don't know how this operates, right? And that kind of stuff is okay with these patients. So we might see some patients with some different levels of intellectual disability. So I'm sure you guys have met people with intellectual disabilities, right? A lot of people call them firefighters. Yeah, cool. Was that too much, maybe? So there are going to be a number of different things that you might see, or a different spectrum you might see of people with different intellectual disabilities. It's really good to try to narrow down what's normal for them. And you're going to hear that a lot when we do this. It's not necessarily what's normal, but we also need to figure out what's normal for patient, right? So maybe somebody with an intellectual or developmental disability wouldn't be able to tell you what month it is, but normally that's not something they would be able to answer. So that's not a very reliable question if we're trying to figure out their level of cognition in that moment in time, right? So we'd have to find out what could they normally answer, because we're looking for normal for patient, right? So finding out those things is going to be really important for us. Some people with these disabilities may be able to live on their own. Some people may not. So you might have a caretaker around as well who can be really good for you to answer questions. It's not bad to get them involved, but just like with maybe kids, if you can talk directly to the patient, that's gonna bridge that gap a lot better if you can. So don't just straight talk over people's heads, right? Regardless of maybe a disability, try to talk to the patient at first, and if you're not getting the information you need, then you can go to the caretaker, right? But don't just skip over. I've seen that a lot, especially with kids. Don't just skip over the patient. A whole bunch of different factors, from genetic factors to like something like fetal alcohol syndrome, or like a TBI. You guys, if you hear TBI, that's traumatic brain injury. So all sorts of things that can cause this as people develop as people. So like I was saying, patients if we can, caretakers, maybe family members can give you a little bit of information. Remember, sometimes these patients maybe will be really challenged if they have the break in their routine. So that could be a daily routine that they're used to. That could be something bigger, right? Maybe if they just moved. That can be really hard for patients with intellectual disabilities. So keep that in mind. And then most of the stuff is going to apply to them, most of the medical stuff. Same diseases, same disease processes. They may be prone to things a little bit differently, but for the more or less, it's going to be about the same. So autism, I feel like autism, people know a lot more about it than they used to. So you guys might have an idea of autism. Again, it's another spectrum, right? So there's no one size fits all for autism. As far as how those patients are going to interact with you or what's normal for those patients. So just keep that in mind. There's all sorts of different ways they can present if they are autistic and different challenges they may face based off their autism. So trying to find out, again, what's normal would be really good for you. There may be some sensory issues with patients with autism. That's something for us to keep in mind. So they may react differently to heat, cold, maybe just touch in general, or maybe they have some sensory stuff. Maybe like tight seat belts are going to be troublesome for those patients. So just keep that in mind if you have one of these patients. Try to be respectful of their sensory response, and if they have any issues with certain things. Obviously we need to keep seatbelts on everybody, right? But we can maybe give them a little more space to make them comfortable, those kind of things. And that's going to go really far for you if you have to treat a patient, right? Having the patient on your side is really, really helpful in these situations. They may respond by, doing something, right? They may have some sort of response to kind of an outside stimulus, especially if they start to get agitated or something's going on. So, kind of some kind of self-soothing kind of things you may see. So you might see that. Doesn't necessarily mean there's anything wrong, but if you can ask, is that a normal response, that can be helpful for you. And then noise can be really hard sometimes for people with autism. So, lights and sirens. Maybe we want to not be as liberal with the lights and sirens as we would otherwise, because we know that can increase anxiety and really cause some difficulty for them, right? So try to keep that nice, calm situation. There's times where you just, if they're having a brain bleed, you need to go lights and sirens, right? That time is of the essence, but in general, be a little less liberal with that, and those kind of stimulatory responses. Less people in the room is usually helpful. If you have a crew of 4 firemen and you've got 2 EMS responders, maybe have a couple of the fire guys or somebody go out, right? Just to stop with that massive overstimulation. If you have somebody near them, like a trusted individual, it says here, that can help comfort them, that can be really helpful too. Or maybe they can give you some input on what the patient likes or doesn't like, or how to interact with that patient. With these patients, family members, caretakers can really be your best friends, because these are patients sometimes where you try to do your normal thing and it just feels like it's out of control and it's not working and you don't know why, right? But if you can have a family member be like, oh no, they really like this, or they really like whatever, they really like to talk about this thing, and you can start that conversation and gain some trust, it can go really far. So having those caretakers around, if they are, use them to figure out those kind of things. Typically short, direct, simple phrases. I would say this really should go for just about anybody, but specifically patients that maybe have some sort of developmental disorder or something. Simple, direct phrases when you're talking to them. And then obviously try to stay away from like the medical talk, right? There's no need for any of that. And then give them a little bit of extra time if they need to maybe process and kind of process what you're saying, process their response, and communicate back to you, okay? Just patience goes really far with patience. Patience goes really far with patience, right? Down syndrome, so that's going to be a genetic chromosomal defect that could have like a mild to pretty severe intellectual impairment. So you guys probably have come in contact with somebody at some point with some sort of Down syndrome, right? So the patients, they have some physical consistencies that we'll see, but again, this is another thing that can kind of be a range. There's plenty of people with Down syndrome that have lived on their own, they've been married, they've had children, they've lived a fairly normal life, and there's some some patients who may really struggle and have to have round-the-clock care. So you might see all sorts of different levels there. Maternal age is going to be a risk factor. So I believe it's over 35 is considered a geriatric pregnancy. I want to say it's 35. And so you're going to start to open up more risk factors for things like this. And then family history is going to be another one as well. So you might see a more round head for these patients with a flat occiput, right? Kind of an enlarged protruding tongue. What does that say to you guys if you know this patient might have kind of an enlarged tongue? What concerns does that give you for treating these patients? Or just what's going to be more difficult to manage for these patients? Their airways, right? Airways might be more difficult to manage. So just keep that in mind if you have one of these patients. They might have a more difficult airway to manage because of the tongue size, which is a normal thing. And then they kind of have, and that's probably the most recognizable thing maybe you guys have seen, kind of the more wide set eyes is a very common for patients with Down syndrome. Increased risk of congenital heart defects and then leukemia. And then obviously for you guys, intubation's not really a skill you can do, so you don't need to think too much about that. But you know, OPAs, MPAs, those kind of things can be affected. It's more specifically OPAs because of the large tongues. So keep that in mind when you're ventilating these patients. It's maybe a little bit difficult, more than it would be otherwise. I really preach that the BVM is one of the hardest skills that we do to do it very well. It seems really easy, especially you guys in here, just done on the plastic mannequins with really good jaw structures. When you get to real life with patients with different faces and facial hair and all that, it can be really hard. So make sure you guys are really good at the easy mannequins so that when you go to have a more challenging patient, maybe somebody like this, you have that good technique that can carry over, right? They may have a seizure history. It's going to be about the same. And there might be some joint instability, which would lead to a risk of complication with trauma. So for the most part, that's a lot of what we're going to talk about with these patients, or just special populations in general. Geriatrics, all that is maybe a little bit increased risk for certain things, but treatment-wise, it's all going to be more or less the same. Kind of like I was talking before, you know, just calm, cool, collected, try to build that rapport that can go really far with these patients. So, you know, talk about them, especially if it's not a high acuity, real sick patient, you know, ask about their interest. If they have a shirt with the BSU Broncos and you're a big Broncos fan, be like, oh, did you watch the game last weekend? Tell me about that. Like, those kind of things can really go really far with those non-critical patients, of making them feel safe and comfortable. And then when they're safe and comfortable, it's a lot easier for you, I promise. So work on building that rapport. Introducing your team members can be really helpful, right? You know, when a lot of us show up, it's really overstimulating, it's really scary for people. And so it kind of humanizes us to go beyond like the shirt and the badge and whatever, especially like, you know, maybe the fire guys are in their turnout pants because it's nighttime and all that, and just looks scary. You can be like, oh, this is captain whatever, this is firefighter whoever, this is my partner EMT whatever, right? It kind of humanizes everybody and makes it a little easier, a little more comfortable. Explaining what you're doing is really good. I'm a big fan of doing this for everybody, but this doubly so for these patients. That maybe, you know, you guys contextually would know if I were to pull out, no, I'm good, thanks. If I were to pull out a blood pressure cuff, you know what I'm going to do, right? You know it's going to go in your arm, you know it's going to squeeze your arm, and you're expecting that. But that might not be the case here. So talk through those things. I'm going to put this on your arm. You know, it's going to squeeze you a little tight, but it's okay. It'll be just for a short time, and we're gonna check your blood pressures, right? Those kind of things can really help. And then you guys have done pediatrics already, right? Have you guys talked about peds? This is kind of the same stuff too. Like staying at eye level is really, really helpful for all patients. But especially for these patients that maybe would have a bit of a fear response to you there. So get down on the patient's level. Don't stand and tower over them. I don't tower over anybody, but if you're tall, you could. So don't tower over people. Patients with brain injuries. Again, this could be a really wide spectrum of patients with TBIs. It could have simple stuff like maybe some some short-term memory issues to seizures to, being fully bedridden. So it could be all sorts of different things that you could see with these patients. All the other stuff goes more or less the same just for these patients, just a little extra caution. So visual impairment could be from all sorts of things. And remember, when we talk about patients being legally blind, that doesn't mean that they're completely sightless and can't see anything. When we talk about visual impairment, it could be, there's different levels of visual impairment, right? So maybe somebody can only see like they were looking out of a pinhole, that's all they can see. Or maybe everything's just really dark or something, right? So don't think that with these patients that there's zero visual acuity, they can't see anything. They just might not see well enough to get a driver's license, right, or something. And we should still be cognizant and aware of that and taking that into consideration when we're treating these patients. If I'm going too fast for you with here, just tell me, okay? You're writing a lot. I just want to make sure I'm not going through the slides too quick for you. Cool. Like I said, there's all sorts of different levels. So keep that in mind. May be difficult to recognize these patients. So if there's some cues around, right, if you see like the red and white cane, if you see them holding that should cue you in like, oh, what's going on? Do you have a visual impairment? What's your visual impairment like? How can I help you with that, right? So try to be aware if you can, but we don't always know, right? You need to be a lot more verbal with these patients than you would be normally because they can't see what's going on, right? So let them know when you walk in if you know it's a visually impaired patient, like introduce yourself again, introduce your partners, tell them what you're there to do. If they have anything that they would normally use, you can bring that with you. So if they have canes, those kind of things, bring that with you. Sight dogs and all that's going to be kind of a gray area depending on your department's policies, maybe the hospital's policies of what they'll allow. For the most part, we try not to bring animals in the back of an ambulance just for hygienic reasons, but sometimes it'll be okay for something like a sight dog, like a seeing eye dog or whatever. So just keep that in mind. So yeah, make sure you have those with them. And then just describe what's going on to your patient. We're bringing the gurney here. It's going to be right behind you. Let me take your hand and guide you to the gurney. Do you feel that there? Okay, there's that gurney behind you. Can you sit directly back onto the gurney? Perfect. Now lay down this way. Let me help you, right? Like walk and talk through everything that's going on, just so they're comfortable with it and they know kind of what the game plan is. Communicate obstacles in advance is really helpful. You don't want to be, walking old grandma who doesn't see very well to some stairs and tell her that there's stairs after she falls down the second one, right? So be cognizant of that beforehand. Tell them, okay, here's what we have going on. Here's what's coming up so that they're aware of that, okay? Hearing impairment, again, can be all sorts of, minor hearing impairments to total deafness. Lots of older people have hearing loss. I think that, I would say our generation, I'm probably a bit older than most of you guys, but, younger people are, I think, much smarter, right? Like, I ride motorcycles. I go to a lot of, hardcore shows. I do earplugs all the time because I'm really aware that I don't want to lose my hearing. Where my granddad, who I'm like third generation motorcycle rider, right? He raced and rode Harleys and all that. Like by the time he was in the 70s, like he couldn't hear a word you said without his hearing aids because he just never thought to do that. So older people, you're gonna see a much higher prevalence of some hearing loss that we're gonna have to work around. Okay. Some things you might see to cue you in, obviously hearing aids is going to be one. So, and there's all sorts of stuff now. You might see kind of implanted up kind of in the hair that comes around. I think sometimes they'll be like magnetized to stick on the patient's head. There's all sorts of cool hearing aids that you might see out there. So take a look for that. They might just not acknowledge you when you're talking, and sometimes that's because they can't hear you, not because they have any medical issue going on. They just can't hear you. So, get in their face. That sounded wrong. Don't get in their face. Get in their line of sight and, wave them down. And sometimes it'll be a little better if they can visualize your lips. But try to consider that if the patient's not responding appropriately, especially an elderly patient, consider maybe it's a hearing loss thing and kind of just try to rule that out if you can. If they have hearing aids and then they are not in, it can be really helpful to go find those hearing aids and give them to the patient so they can put those hearing aids in. Sometimes it can be a little challenging, especially the people with real bad hearing loss will turn their hearing aids up super loud and all you hear is like ee from the hearing aids because they're so loud, just feeding back off each other. But if that's what you need to do to communicate with the patient, that's what you need to do. Facing the patient is really helpful if they are used to reading lips, because maybe they have limited hearing, so they hear a little bit, but if they can see the lips, they can kind of tie it together. If I'm talking to them like this, not facing them, they have no idea what I'm saying, right? So if you're looking at the patient, making that eye contact so they can see your mouth move, it's going to be really helpful. You don't need to exaggerate your lip movements, right? That's I feel like that can be kind of insulting for people. Don't talk louder. Don't start yelling at them, right? Just talk normally to them. And if they need you to slow down or something, they can tell you to slow down, right? Just start normal, and if they need something, they can tell you what they need. Yeah, don't speak louder. Typically, if you can kind of bring your voice down a little bit, they might have that higher register hearing loss, or the lower register, they can hear a little bit better. And so they might have better hearing in the lower register, so it can help with that. If you know any sign language, might be a good time to pull it out, hit them with some sign language. You know, there's a lot of really good apps and stuff now that you could pull up on your phone or even YouTube. If you have a specific question, I'm sure you could YouTube some words or look it up online and be able to get that sign language to ask them, some simple stuff. Paper and pencil can be really helpful too with these patients. You can write down your question, they can read it, and they can answer it, or they can write it back, and you can go back and forth that way. There's a lot of things that we can do with this. I had a patient one time who, he was a truck driver at the truck stop that called. And we got there, and he was hearing impaired. And so he had a tablet, I think, or a computer, or something that he was connected to, that he was talking to somebody, like signing to somebody on a webcam. And that person had called his cell phone, and he handed us the cell phone. So we would talk to the person on the cell phone. They would relay it by sign to him over the laptop or whatever it was. He would answer back, and then they would relay it to us by phone. So, you know, there's a lot of options that you can do. If you can, keep that in mind. And then the hospital, they really appreciate when you give them a heads up if you have somebody that might need a sign language interpreter, really any interpreter. Most of the hospitals will have like a little robot guy that they push around that will have a screen with an interpreter if they don't have somebody there in person. And if you let them know beforehand, they can get that all ready so that there's no delay in patient care waiting for a translator there, right? So this would be the same thing. And then reverse stethoscope, it would be kind of like an EMS hearing aids, right? You can put the stethoscope in the patient's ears and then talk into the bell, and that will help to increase the volume for them. So maybe that can help them hear when you're talking to them, okay? So another thing you can try out if you're really struggling to communicate with a patient. A couple basic signs here. Again, you can look something up. You know, if you guys go get hired at Boise Fire or wherever, Meridian Fire, and you know that there's a patient in your district that that uses sign language because they're hearing impaired, for sure then it's a good idea to go learn some basic signs, right? And that goes for anything with any of this, right? You know, here on the Boise bench, there's a large refugee population. So maybe you know that there's a large refugee population from a certain area that all speaks the same language. You can go start to learn just some basic words like hello, what's your name, does anything hurt? You know, you can learn some basic stuff like this if it's a patient population that you're running on consistently. And it can go really far. Show them that you're really there to help them, right? You're really their advocate. Hearing aids, obviously they're going to make sound louder. So they could be external or internal, like I was saying. There's all sorts of different ones you might see around. You might hear that whistling like I was talking about, that kind of feedbacky thing. Sometimes they're just cranked up too loud. They're not really snug in there. Not really much we can do about it. But if the patient has hearing aids, try to bring them with them or make sure that they have them in. Okay, you don't want to leave those at the patient's house and they go to the hospital and now they don't have their hearing aids, right? So if they don't have them in, either put them in or bring them with you. Cerebral palsy, so it's going to be a group of disorders, and it's going to be kind of that poorly controlled body movement, right? All sorts of different things, again, that can cause cerebral palsy. It could be kind of like a birth thing. It could be like meningitis. There's a number of things that can cause cerebral palsies. So it's going to be kind of uncontrolled spastic movements. They might have some difficulty communicating. They may be wheelchair bound. Most of this is going to be really straightforward with what you'd expect for patients who have this kind of disability. Make sure you're being aware of their airways. Bring the wheelchair if you can. Don't force extremities in position. All straightforward stuff, right? This is pretty logical stuff for treatments of these patients. Spina bifida is when the spinal cord's exposed because things don't close up correctly. As far as I know, they can generally find this before the baby's born, so they might be aware of this beforehand. But this can cause some long-term, like lifetime disabilities. So this can happen. They can fix it, but it might be already at that point that there's some sort of issues that happen down the line. So paralysis, those kind of things. So keep that in mind. You might ask, especially when we have babies as patients, it's very common to ask about what pregnancy was like. That was all normal. Is there any abnormalities on birth and those kind of things? You might hear spina bifida. So ask if they have any known issues because of the spina bifida and just see what they say. Paralysis, this is another patient population we might take care of. There's different levels, right? So somebody could be paraplegic or quadriplegic depending on if they've had like a spinal injury and where that spinal injury was. So just keep that in mind. It could be from a stroke too, something like that, that would cause this because they didn't get they weren't able to manage those symptoms. So again, most of this is straightforward. You're just going to have to treat the patient as you would think you'd have to treat the patient typically if they're going to be a patient who suffers from paralysis. The diaphragm is one of the big concerns for these patients, especially that's why we're concerned about like a high spinal cord injury because we have the diaphragm, that's our main muscle of function for breathing, right? And if that's innervated because of an injury or something, we're not going to be able to breathe very well, right? Do you guys know where in the spinal column the nerves come out that correspond to the diaphragm? There's a little saying that we like that goes along with it. 3, 4, 5. See, 3, 4, 5 keep the diaphragm alive, right? So if you have a patient with a known like high spine injury, 3, 4, 5 in the cervical, really make sure you're thinking about ventilation with that patient if necessary, right? Especially in the short-term traumatic kind of a thing. You might see things like urinary catheters. You guys all know what the urinary catheter is, right? How about a tracheostomy tube? You guys know what that is? What's a tracheostomy tube?
Isn't that the tube that goes in your neck?
Yeah, so it's going to be the tube that kind of goes in your neck. So they will go right into the trachea. They'll create an opening into the trachea for a breathing tube, essentially. How about colostomy bag?
It's a poop bag.
It's a poop bag, yeah, exactly. And then feeding tubes are going to be usually called like a G tube, a gastric tube, and so that's going to go into their stomach so they can get fed. Typically, it's kind of like a brown kind of gruel looking stuff that they'll feed them, just like pure nutrition directly into their stomach. Not a bad idea to ask them how they normally get moved around. Okay, they might have something called a Hoyer lift or something similar. So a Hoyer lift, they have a specialized bed sheet that has kind of handles all along it, and there's a lift that you kind of wrap them up in the bed sheet and it hooks onto the lift and it can lift them up and over and onto your gurney. That might be the best thing for them, most comfortable thing for them, or just ask them before you move if you can, right? If they're critical, we're going to be a little bit less concerned about this, but if they're not critical, ask them kind of how they like to be moved to the gurney and how they like to be put on the gurney so they're most comfortable. Bariatric patients, we are going to see way more than any of these other patient populations, obviously. You know, America's fat, if you guys didn't know. America's fat. Fat people, overweight people tend to be more prone to different diseases, and so overweight people are more likely to call 911 because of those diseases, right? So obesity is going to be 30% over the ideal body weight. Severe obesity is going to be more than that. If you guys didn't know, it's an imbalance of calories consumed versus calories used. So pretty much they eat more than they burn, right? There's all sorts of issues you may see with this, including mobility difficulties. So these are patients that maybe it's a very common thing for us to get lift assist calls, is what we call them, where a patient falls down and for whatever reason they can't get themselves back up off the ground. And this is going to be kind of the prime patient population for that is going to be elderly, overweight patients who are really heavy and aren't exercising enough, don't have the strength to get themselves out of whatever position they fell in, right? That kind of thing. Diabetes is going to be more common, hypertension, heart disease, all the stuff that you would think is going to be more common for these patients. So is it going to change our treatment for the most part? Not really. We just need to have a bit of a higher suspicion for these patients. Patient may be embarrassed, like those fall patients sometimes are pretty embarrassed about it. You know, we might have to lift a patient. They're going to be embarrassed if we have to lift them and move them, right? And the amount of times I've had patients apologize, you know, and it's always somebody who's mildly obese and like, oh, I'm so sorry, I'm so overweight. And so it's usually, look, if you've seen what I've seen, you wouldn't be too worried about it, right? Like we go on patients all the time, try to make them feel comfortable, like it's, you know, there's nothing really to be embarrassed about. It's okay. Think about getting that extra help if you need it. I've been on a scene where we had to get a fire engine and a fire truck out. So we had like 9 people on just to help get a person out of their chair onto the gurney because they weren't able to stand. So we couldn't just stand and turn or anything. We had to actually physically lift them. And I think they were probably like a 500-pound patient, something like that. So it's a lot better to take a little time, wait for the correct resources so you don't drop a patient, you don't injure yourself, right? Just take the time, get those correct resources. Always be looking for the easiest way to get out. And this is something you guys should be doing regardless of the patient or the situation. You guys will start to do that if you start working in this field where you walk into a house and you're already looking like, I see stairs there that I'm going to have to navigate if they're upstairs. I see this. This is a weird narrow hallway that's going to be hard to get through. Like be mindful of that as you're walking in. Maybe the best way to go get this patient out is to go through the back door, not the front door, right? Because for whatever reason. So be thinking about that as you're entering the scene, be thinking about how you're going to exit the scene. And like I said earlier, just wait for the resources. Don't do something that can make you maybe drop the patient or get somebody hurt, right? Get those correct resources. Even if it takes a little longer, it's better in the long run. Always try to avoid lifting by one limb. So if you're going to lift somebody up, don't just have them give you one arm and try to lift them with that one arm. That's a lot of strain on that one arm. Could cause a lot of issues. So, you know, think about those things. There's all sorts of stuff you can do to help patients get around. You know, you could take a blanket or a towel and wrap it and go under their armpits from the back, and somebody can help there while you help pull, you know, have them with their arms, stabilize their arms, all sorts of stuff. So think about that. And then really having a good plan and good communication of the plan prior to starting a lift or moving a patient. This is any patient, but doubly so for heavier patients, is really, really helpful. So take that time, make sure everyone's on the same page, we all know what we're doing, and then move that patient, especially if they're very, very obese. Keep in mind, larger patients may have difficulty breathing if they're in a supine position, just because of body mass, right? We breathe by making our chest cavity larger, and that takes muscles to make our chest cavity larger. So if they have a lot of extra tissue on that chest cavity, it's gonna be harder to expand it, and so laying flat can be more difficult because gravity's fighting against them, right? So you might wanna have those patients sat up or just ask them if they need to sit up. There's also specialized equipment Have you guys seen pictures or anything of like bariatric ambulances? Has Kylie shown you that? Yeah, so that's something to think about if you have that. That depends on where you're at. The first service I worked for, we didn't have anything like this. Ada County paramedics, they have the bariatric unit that has a winch and it has a bariatric gurney and everything. So just know your resources and utilize your resources. And then the receiving facility might be, it might help to give them a heads up a little early if you have a patient that they'll have to make some accommodations for, right? So think ahead a little bit for your patient's sake and for the hospital's sake. Any questions so far? I know this isn't exactly riveting stuff. It's not as fun as like the trauma medical stuff, but it's good stuff to talk about. So tracheostomy tubes. We're going to call that opening a stoma. So a stoma is going to be right there in the neck. And typically there's going to be a tube that goes down, kind of like an intubation tube almost, that's going to go down to keep it open. Some patients will have just kind of a single tube, and sometimes there will be a tube within a tube. So they'll have like a tube that is kind of more permanent, and they can swap those out as needed as they start to like get nasty. So just keep that in mind if you have to manage one of these. You might have multiple tubes in there. Usually if you remove the first one, you can replace it with something different. And then it may bypass the nose or mouth, or it may not. There's open tracheostomies and there's closed. So sometimes they will seal the trachea up above the opening, and sometimes they won't. So if you have a patient that you're trying to ventilate and they have a tracheostomy, and it's an open tracheostomy that's open above that spot, what's going to happen when you breathe for them? Where's that air going to go? It's going to go out of the mouth and the nose, right? So make sure you're double checking that if you're ventilating these patients. Make sure there's no air leakage from the nose and the mouth. You might have to essentially cover the nose and the mouth so that no air gets out there. And maybe they're not, and maybe it's just a closed trach and you're all good there. Some could be temporary, some could be permanent. Just know that some people, it could be how they live their life all the time. Some may have a ventilator at home that you're going to have to maybe manage. So it's really hard. There's all sorts of different ventilators. We're not going to know all the settings for all the ventilators for all of that, right? Hopefully you know kind of what their normal is. And then, like I said, if they're on a vent and it just doesn't seem to be working, their SpO2 is low, they're having difficulty breathing, all that stuff, we can always just manage it our own with the BVM, right? We can remove that ventilator and we can use a BVM on these patients. So typically it's going to come down. There hopefully will be a little bulb here, right? And so that should be filled up with air to keep air from passing up above it. But it will fit, our BVM will fit right on the end of here. Okay, that's one thing that's really nice. All the companies, we do have some standardized sizes for some of the equipment, and this is going to be one of those. You can put your BVM right over it, okay? These are a fairly good size. You guys probably haven't seen any soft suction catheters. We typically have you guys practice with like the rigid Yonkauer style ones. But they do make soft suction catheters that are fairly long, and there's different diameters. And so it's not uncommon for these patients to have like some mucus buildup or something kind of build up there that we'll have to suction out. And they should be good about suctioning, but maybe they're out of suction supplies, maybe they're new to it, maybe they're sick and just don't feel up to it. Whatever reason, we may have to go out. And I've helped suction a couple of these before. And it's a simple thing. You'll just get your soft suction. You can run it down there. You can spray a little saline down in there too if you have like a saline flush. So you can spray a little saline down there to hopefully break up that mucus plug if there's a mucus plug, and then you can suction it out, okay? You don't want to go too far. If you go too far, you'll typically know pretty quick because you'll hit the carina where the lungs kind of split there off into the right and left, and they'll kind of give you a little something if you hit it. So just go as shallow as you can and still be effective. You should start to see some chunks and stuff coming up through there if you're suctioning. But hopefully I've been on patients before, this is all we did. For whatever reason, they couldn't suction their own trach. We got called out. They were having some trouble breathing. We sprayed a little saline, suctioned it out, got it all good. And they're like, cool, thanks guys, I'm good now. And we left. So that does happen sometimes. Dope is a little mnemonic. I'm sure you guys are sick of mnemonics because we use mnemonics all the time in EMS. We love our mnemonics, but dope is another one. You're definitely going to hear this if you go up to higher levels, advanced or paramedic. This is what we use for advanced airways and that kind of thing. Dope is one of the ones we like. So it's going to be, the D is going to be displacement or dislodgement of the tube, right? So maybe that tube got pulled, something like that. Maybe there's an obstruction. That's going to be the O. P is going to be pneumothorax. What's a pneumothorax?
Air in the pleural area.
Yeah. More commonly called a collapsed lung, right? But air in that pleural space. And then maybe it's equipment failure, right? So these are just some things if you have a patient who's having difficulty breathing and they have a tracheostomy tube, or or you're doing some sort of advanced airway and it's not working correctly. This is a quick little list that you can go through to run through in your head of like, okay, is it dislodged? Nope, that's good. Is it obstructed? Let's try to suction it, work your way down through there. So some common problems, we could have that air leakage like we talked about. So sometimes those little bulbs at the end that I showed you guys, sometimes those get punctured and they don't seat anymore, and so you can have some air leakage around that. You might have infection. Obviously there's nothing we can do for infections, but as you can imagine, it would be more prone to build up a mucus and all that stuff. And so they're going to be more prone to getting clogged up. So you might have to deal with that, but there's nothing we can really do for infection. Of course, my Teams is just going off today since you guys are in here. Not really much to say outside of what I already said there. I think it comes up later in the slideshow, but one thing you can always do if you have a patient with a trach and they don't have anything for you to attach a BVM to, you can take preferably like a pediatric size BVM mask, and you can place that right on the neck over the trach and you can ventilate that way. That's something that you can do if you have to. HOMO 2, you might see a couple different ways that patients will get their HOMO 2. So they might have the cylinders like you guys have been practicing here. They'll probably be bigger, but you might see those, and they might have some that they carry with them when they go out, right? Or they can have a concentrator. So those are typically pretty good size that sit kind of in a corner plugged in, and you turn them on, and instead of having to change out cylinders, it pulls atmospheric air in, pulls the oxygen out to increase the oxygen percentage, right? So you might see that as well. Oxygen cylinders obviously are a little bit easier, where the concentrators can just run more or less indefinitely. Okay, so there's upsides to both. One thing you might see patients with the concentrator is if I'm only going to have one concentrator, right? And that's going to be in my bedroom or my living room or wherever. Now I need to go to the toilet, right? So you might see, 200 feet of oxygen tubing throughout the house. It's all running. So again, I've been on a patient where short of breath, they have their nasal cannula, they live on all the time, they're just really struggling to breathe, and we just kind of followed that, and it was kinked around the corner. We opened it up and kind of smoothed it out, hung out with her for a couple minutes, and she's like, oh, I feel so much better now. It was just her oxygen level, her oxygen tubing was kinked. So keep that in mind when you have those super long oxygen tubes. That can happen to patients. One thing that's important for the concentrator is it needs electricity to run. Okay, so at least here locally, there is laws in place and everything that for patients with this, if they don't pay their electricity bill, the electric company won't just come shut them off. So I have been on a call where we had to contact the electrical company because they shut the person off. They're like, hey, they're on a concentrator. Oh, we'll get them right back on, and they turn it back on, right? So keep that in mind. But obviously, the hurricanes that happened, if there was patients on a O2 concentrator at home, those hurricanes are coming, knock out their power. Now they're without their normal oxygen. So that can be a concerning thing. Hopefully they have some sort of backup in like the normal oxygen cylinder that they can use. Ask them why, how long they've been on their HOMO 2, if they've had to change it or anything recently. What's their normal baseline for how much are they normally on, and what's their baseline oxygen saturation. Okay, especially like old COPD patients. I've seen multiple old COPD patients that live at the high 80s normally. That is their normal oxygen saturation, right? So if you guys don't know that and you show up and they're complaining of something, you're going to put the SpO2 probe on their finger. You're like, 88, I better start throwing oxygen on this patient. This patient is an extremis, right? And that might not be the case. If you guys remember, what happens to patients that are hyperoxygenated for a long time with COPD patients? You guys remember carboxyl drive versus hypoxic drive? Yeah, so carboxyl drive, my body tells me to breathe because I have what? I have too much CO2, so my body tells me to take a breath to get rid of CO2. Hypoxic drive, my body recognizes I don't have enough oxygen, so I need to breathe to get more oxygen, right? So normally we have a carboxyl drive. Hypoxic drive is what typically happens to late stage COPD patients. So their body needs to recognize I need more oxygen. If we slap 100% O2 by non-rebreather on these patients that don't really need it, they're going to be so filled with high concentration oxygen, it's going to start to affect their respiratory drive. Okay, so that's why we want to know what their normal level is and just shoot for that. Patient tells you I normally sit at 92 or 93. When we're at 92, I'm happy. We're cruising. We're looking good, right? We don't need to go above that. Ventilators, unfortunately, we don't have one here for you guys to kind of mess around with. But like I said, they are very complex machines with all sorts of things that you can change on them, from percentage of oxygen delivered to the tidal volume, so how much each breath they're giving, how often is breathing for them. There are some that just breathe 20 times a minute or whatever you set. There are some that will only breathe when it recognizes a breath, and it will help to assist ventilations. There's all sorts of different things for the ventilators. So you guys are never going to know enough about this stuff. Maybe if you're a respiratory therapist, but for the most part, you're not going to know these machines super well. So just go into it knowing that you're not going to know them very well. Your best option is going to be a BVM in this situation. Yeah, that's what I was saying before. You can place a BVM mask over that stoma as needed. Hopefully the caregiver is going to know how the equipment works pretty well. Family members typically are really, really up on it too. Even if they're not a caregiver, most family members are good. Or obviously the patient hopefully knows how that operates and they can give you some insight onto it. I would say more than anything though, if you have a patient on a ventilator, don't just go start pushing buttons and changing things, because then you could really cause some issues. So we've got good hands and good BVMs. Use one of those before you start hitting buttons. Apnea monitors, you might see these. These go on little babies, and if baby stops breathing, it's going to alert mom and dad so they can check on the baby, right? So you might see that premature babies or severe gastroesophageal reflux, because they're just more prone to breathing issues or to periods of apnea. Or a history of SIDS. They might have like family history. Obviously, if there's a history of SIDS, that baby, the previous baby perished, so it would have to be a history of SIDS, right? So you guys remember SIDS, sudden infant death syndrome. This is going to go on those babies, and typically it's going to be kind of like a life-threatening event, or maybe they have experienced something similar like a life-threatening event, and this will go onto baby. Pretty straightforward, pretty easy. Pacemakers, you guys probably have talked about pacemakers a little bit. If you see one, it's good to recognize it and to really be looking for pulses and all of that. Typically, pacemakers are going to be set like 60 to 65, somewhere in there is what most pacemakers are set at. There are demand pacemakers that only kick in as needed. So if the pacemaker recognizes somebody's heart rate is below a certain rate, it will kick in. I don't know if I would imagine it's actually more like if there's not a beat every 1 second, it will wait a second and then hit them, right? It'll give them a little extra beat as needed. So there's on-demand pacemakers, and there are pacemakers that the patient just lives on 24/7, and that's just how they live, right? There may be an implanted defibrillator. There may not. It depends on their history and what they need that hardware for. We don't want to place our pads directly over these, right? Typically, they're going to be on the left side. they place them onto the non-dominant side. Most people are right-handed, so they place it on the left side just because there's less usage of those muscles that it's underneath. But we put our CPR, our EKG pads up here. So normally it's not too big of an issue. But if it is on the right side, just make sure you avoid it. You don't want to go directly over that. Ask questions about the pacemaker. Some of these patients, sometimes those pacemakers, especially newer ones, will have some sort of little hub at home that it can communicate. Maybe it's even taking an EKG and can communicate with that. So if you're able to get that information to pass along to the hospital, that's very, very helpful. If you have a patient with an implanted pacemaker and there's an issue with the pacemaker, paramedics are really good people to call because we can externally pace. So we can put our cardiac monitor on, we can do the same thing. It's more painful because it has to go through the body tissues, but we can externally pace these patients. So sometimes weird stuff happens. I had a patient who had an implanted pacemaker for a long time. Pretty sure it was just kind of dying. He was just starting to give up, and there was a 13-second pause in his heart rate at one point. 13 seconds was how long it took for one beat to the next at one point. So those patients, as a paramedic, I can slap on some pads and I can pace them, get them to the hospital so that they can get a new pacemaker taken care of. LVADs, have you guys heard about LVADs? Yeah, left ventricular assist devices. So usually not going to live on this forever. It's usually a bridge to a heart transplant or something. You may be able to palpate a pulse. You may not. Some of them are pulsatile and will push out a pulse. Some of them are just constantly going, essentially. And so if it's constantly going, we can't find a pulse, we can't find a blood pressure. It just doesn't work. So just keep that in mind for patients with LVADs. Again, there's not much. If they have an LVAD dysfunction, there's literally nothing we can do for that. We can't fix that, right? If there's a dysfunction there. You might have a caregiver that can answer some questions. They should have like a phone number or something for like a manufacturer helpline to talk to a nurse that you can call. You can always use that option. And then CPR may be helpful or may not be helpful. That is something that typically if you're in that situation, which is exceedingly rare, but if you are in the situation, you might want to call that helpline to ask if CPR is going to work, because it might not. You know, if they just have a big hunk of metal and plastic in their chest, there's nothing for us to compress, and so CPR is just going to be damaging the patient's soft tissue. So, but if they need CPR, I'd rather start CPR if I'm not sure and have it not be helpful than not do CPR when it could have been helpful, right? So Kylie might have told you too, something you can do to check on these patients, you can listen over their heart and you might hear because a lot of the time it's like an impeller in the little thing going just humming as it pushes blood out. So you can listen for that hum where heart tones would be to see if you can hear that LVAD working. I don't know that this is really a very common thing anymore, but there are defibrillator vests. So most of the time patients will have an implanted defibrillator. So if they are prone to long periods of VTAC or something, they'll have an implanted one that will shock them like an AED does. It does not look fun. I've had patients before who like every like 15 seconds they're like, oh, here it comes. You doing okay? Yeah, I'm doing okay. And then like 2 minutes later, oh no. And boom, and they would just, just get lit up every couple minutes. So maybe that will happen. If the implanted ones aren't too bad, the external vests, that is a thing that you can still see out there. And so that's going to have a much larger amount of electricity typically. You might see central catheters. And so this is going to be venous access, usually for long-term care. They're typically not going to do an IV like you guys would see or what we'll do in EMS for long-term care. Typically, they're going to do a central cath. And there's a picture of it coming up. But typically, the chest or subclavicular, somewhere up here, upper arm is mostly where you're going to see these. So yeah, something like this. There's usually a couple different ports. Depending on our protocols as paramedics, we maybe can access those, maybe cannot. Really depends on how well we're trained. Usually there's a lot that you'll have to do, like you'll have to use like a heparin push or something, so you're making sure you're not pushing blood clots anywhere. So maybe you can access those as you get to higher levels, maybe not. Infections is going to be probably the most common thing that you're going to see from those. If you have somebody with a central catheter that has an issue, is there anything we can do? Nope, take them to the hospital. Not really anything we can do about it. G-tubes are typically going to be kind of the same thing. So they can be going through the abdominal wall to the stomach, or they can be coming down through the nose or the mouth, okay? So just gastric tubes, fluids, all that kind of stuff, so that needs to go down to the stomach. Again, if you guys become paramedics, you can do G-tubes. We can do, obviously not through the abdominal wall, but we can do nasal and oral G-tubes. OG NG tubes. They're actually kind of cool. They're kind of fun to place. Way easier than you would think. So you might see something like this on a patient with a G-tube. If it becomes dislodged, make sure you stop. We don't want to be feeding anything into like the peritoneal space or anything where it's not supposed to go. That's just a huge infection risk. So if it seems like it's dislodged, we're going to shut those down. We're not going to push anything through it. And then, so symptoms of bleeding in the stomach is something else we'll be concerned about with these patients. So that coffee ground emesis, you guys know what that specifically is called, the bloody emesis. Hemat emesis, hemato like blood, hemat emesis. That's typically a really bad thing. I'm sure you guys have heard about bleeding in the stool or whatever. That darker coffee ground, bleeding in the stools is worse because that means it's higher up and it's being digested. That's why it looks like a coffee grounds. So keep that in mind. What are you doing, buddy? You guys all good with the dog in here? No issues? Okay. Hopefully you're on camera. If they're having difficulty breathing, sit them up. Most of the stuff is pretty straightforward. And again, a lot of this we can't do anything for. So you might see patients with shunts, especially because of a neurological condition. So that's going to allow fluid to drain out typically of the cranium if they have an excess fluid in there. You might see it kind of behind the ear, so kind of a bulge behind the ear that's under the skin there. There's not really much we can do about this, so not really much for us to talk about with these. Just if you're seeing kind of stroke symptoms or general neurological symptoms with these patients, right? And you know they have a shunt, just be concerned. Maybe it's something to do with the shunt. Maybe the shunt's blocked. Maybe there's an infection in there or something like that. And that's going to be a high priority patient. If they have some piece of equipment going up to their brain and they're acting abnormal in their brain, that is very concerning. That's a high level patient we need to be concerned about. Vagus nerve stimulators. You guys ever heard of these? These are kind of crazy. So we have the vagus nerve. Do you guys know about the vagus nerve? Has Kylie talked about like the vagus nerve, and it's the one. It kind of runs down. It's one of the cranial nerves, and it can like drop your blood pressure and stuff, and it does a lot of stuff. If you guys have seen like, the dude flexing in the mirror really hard that passes out, it's because they stimulated their vagus nerve so hard that it dropped their blood pressure so they passed out. But we can have these. Our patients can have these implanted stimulators that will stop seizures. So it somehow recognizes seizure activity and it will stimulate the vagus nerve to kind of help with that seizure. Gonna be 12 years or older, under the patient's skin. Don't do anything different for them. Colostomy bags, you might see those kind of out here. Like we said earlier, they're poop bags, right? And so they're gonna be usually through the abdominal wall. It's usually going to be kind of an external like clear bag that you're going to see hanging off that they can change out as needed. Hopefully they're emptying it or changing it frequently. They may have some dehydration if they're losing more fluids, which is the same for anybody with diarrhea or vomiting. Most of this is the same as what we've talked about before. You might see a urostomy, which is going to be a similar thing for the urinary bladder for patients that for whatever reason can't urinate through the urethra. And so this is going to be how they drain their urine, is going to be into a bag outside of their body. So a urostomy is different than a urinary catheter, right? Urinary catheter is going to go into the urethra. This is going to be outside of that. So for patient assessment for these guys, usually caregivers of the patients are going to know the most about it. So like I said before, with all these things, you can rely on them to give you some good information, right? So ask a lot of questions. And then, like I said before, normal baseline is really important. What's normal for these patients? And then what's different today? What has changed for us to have to show up to date, right? Home care, you guys doing okay? I don't know how long we've been going for. This one's a little longer than I thought it was. Let's just power through if you guys are good with it. I think there's only a couple more. We'll knock this out. Home care obviously is going to occur at home. That's why it's called home care. And it can be everything from little babies to adults to old people, all sorts of different age ranges and all sorts of different reasons. So and it could be different levels. It could be something simple up to full round-the-clock home care for these patients. We might get called by the home care provider, so make sure if that's the case, asking them why they called, what was their concern as we're talking to patients. So this is one of those things where we can kind of divide and conquer with this kind of a thing. So if I'm the lead EMT paramedic on that call, I'll probably go talk to the patient, at least initially, to get a good baseline assessment of the patient. And I can tell my partner or one of the firefighters or whoever, whatever, whoever's there, hey, go talk to the home health provider, kind of get an idea of what they're concerned about, what they were seeing, and see if those things match up. Maybe they're a little bit different, and we can go from there. Hospice care is typically going to be end-of-life care for patients that don't want to die at the hospital. And this is a super common thing. I don't know about you guys. I would much rather, if I was 90 years old, I'd much rather die at home than I would in the hospital if I know it's coming, right? So it's a pretty common thing. Typically, they're going to have a DNR order. You guys, I'm sure all know about DNRs. We pound that one pretty hard into you guys. There might be the orders for a specific scope of treatment. Have you guys seen the Idaho Post form that has kind of our DNR form? It's actually a post form. It's the physician's order for a scope of treatment, something like that. But so Idaho specifically, it has a box. Do you want CPR? Essentially, yes or no. And then do you want care? And there's aggressive interventions. There's a couple different levels, right, of different interventions that they might have checked. And they can do stuff specifically of what they want. So, and sometimes it's weird. It's not what you would expect. But just make sure that for especially these patients that tend to have these, look those over so you're not going outside of what they want. Maybe they want, maybe they want you to no CPR, but they want you to use a BVM or ventilate for them as necessary with no airway adjuncts, right? So you want to know that before you start to treat those patients. Just make sure you're asking about those if they are in the situation where it would be a concern for you. So comfort care is a common thing that you might see. These are patients that they know that they're at end of life. They're generally, I would say, accepting of that, but they don't want it to be a bad transition, right? They want to go comfortably. Pain medication, ventilation, those kind of things. Bring it to the hospital if you can. The hospital may have a copy of it. They may not have a copy of it. So if you can bring a copy with you, that's helpful. Try to have a copy if possible so it's in multiple places. But that way if something happens and you're like, oh, the patient has a DNR, like, I don't see it. I can't follow that. You want to have that with you, okay? Some places, at least when I went through EMT school a long time ago in California, their requirement was a wet DNR is a terminology they use, that they had to have the actual signed one by the doctor and the patient. Idaho's not like that. You can have a copy and we're still going to follow the copy. I'm sure, and I don't want to go too much into it because this is a really hard topic for us to talk about, but family wishes at the end of life can be really difficult. I would imagine Kylie talked about that sometimes the family's wishes go against the patient's wishes with DNRs. That's something that you guys will maybe have to navigate in your career down the line. So just keep that in mind, that might be something you'll have to come up against. Of the patient has a DNR, they're unconscious, family's like, save grandma, and how you have to manage that, right? So it can be really difficult, one of the most difficult things we have to deal with. So just keep that in mind. And then it's very common for hospice patients to have a stipulation that they cannot go to the hospital for certain things. So if I'm on a hospice patient, especially one that's not super critical, I'm always going to try to get the hospice nurse on the phone to explain the situation, because there's been a lot of times where the hospice nurse is like, well, that's why they're home. I'll be there in 15 minutes to come treat the patient, right? It is possible for the patient to be taken to the hospital for certain reasons, and that be kind of the end of their contract with their hospice company, and they'll have to go through the process again. So if you have the ability to contact the hospice company, talk to a nurse, talk to whatever, explain the situation, it's just really good patient advocacy to talk things through with these patients. So that's something I didn't know at first, and there's been a lot of times where I've taken that time, and the hospice nurse is like, thank you. They don't need to go to the hospital. We don't want them to go to the hospital. We'll treat them at home. Homelessness is something that we deal with a fair amount here locally, depending on where you work. I always worked downtown when I was at Ada County. I really enjoy going on the homeless population. It's just, I don't know. I feel like it's a societal issue that I can kind of help a little bit. That was my way of giving back to the community, is I think by showing care and compassion to the people that I think really need it. So I don't know. I have a soft spot for the homeless population, but it's something that you might go out on. There can be all sorts of different reasons why patients are in a shelter or something like that, right? It's not just it's not just because they have alcohol abuse issues or drug abuse, right? It could be there's a women's spot downtown that's just for women. That a lot of them, they're leaving like a domestic abuse situation, and that's why they're in the shelter. All sorts of things, right? So just keep that in mind so that you can really keep your compassion where it needs to be for these patients. But all sorts of different reasons why they could be there. It's really good for you to kind of be aware of the services around you for these patients, right? Because maybe they don't need to go to the hospital. Maybe there's something else you can do for these patients that's going to be best for everybody, right? But I always say for 911, when you guys are kids, right? And something bad is happening you don't know how to fix, who do you call? Call your mom and dad, right? When you're a grown-up and something bad is happening that you don't know how to fix, who do you call? Call 911, and we show up and we fix it, right? And so that's doubly so for patients in these harsh economic situations and whatever. We're going to be there because we're not going to tell them no, right? If they need help, we're going to show up and we're going to help them. And sometimes going to the hospital is not the best way to help them. Sometimes there's other things. So like we have Faces of Hope downtown for domestic abuse victims. There's all sorts of resources. Wherever you guys land, know your resources, and kind of use that as the best way to treat your patient, not just necessarily rush them to the hospital and ambulance.